Hello, nurse researchers. So delighted you are here for Unit 1 as we begin exploring the wonderful, brave new world of nursing research. I do hope that you will become an enthusiastic consumer of research and really be able to dissect and apply research in your practice, but also in your future when you will conduct your own research that impacts patients' lives. How powerful that is. I want you to look at this slide and know that this represents Unit 1, Chapters 1, 2, 3, and 4. You see the course objectives listed, and you will also be able to find the class objectives that are testable at the beginning of each chapter of your textbook. As we begin Unit 1, just know that this is a broad overview of the principles. The specifics about research and some of the terminology and language will certainly come as we progress in this course, but we're going to do an overview with this session. And what is nursing research? Well, it really means just to search again or have a discovery. It's a systematic, objective process of really analyzing phenomena of importance to nurses. With this, we refine existing knowledge, also called applied research, and we also generate new knowledge about nursing, which is known as basic research. And everything about nursing research, it includes all the studies that concern nursing practice, nursing education, and nursing administration as well, because all of it really examines why we do what we do as nurses. And that's what research is. Now, fortunately, we have a wonderful, rich history in our nursing research past. Even today, NASA, the space people, really appreciate and value nursing research because in all of this space race kinds of research they've done, they have included nursing research regarding wound care and medication delivery systems and how to manage chronic conditions and all those kinds of things. So our four sisters and mothers in research really did us a favor. And of course it all began with Florence Nightingale in the 1800s. And I know you know that she is really the leader for nursing and has gave us a beautiful start to a wonderful discipline and profession. She began her work in the Crimean War, and here she taught nurses how to record observations in a systematic way, and she really pioneered environmental health hazards about changing dressings and sanitation and how to feed the troops and keep disease from spreading. And so her work really is some of the very first nursing research that was ever conducted, and a very powerful influence to this day. Now, our first journal of research, titled Nursing Research, came about in the 1950s, and it was the first peer-reviewed, P-E-E-R, reviewed journal. And you think, what does that mean? Well, peer review means that when an article or research is submitted, that there's a panel of experts that review this work, and they don't know who the authors are, but they review the work for rigor and integrity, truth, and then it is published. And only then when the experts agree that it is worthy. So it goes through a good bit of rigor before we read these articles in what is known as peer-reviewed or refereed journals. So when you go to the Oncology Nursing Journal or the Nursing Management Journal, you know that what you're reading has been put through the paces and has been given the mark of distinction. So this Nursing Research Journal was one of the first that came about to talk about the scientific work nurses actually were beginning to do. So that's a powerful thing to remember, and I encourage you to highlight that. Also, rounds about 1986, the National Center for Nursing Research was established by the National Institutes of Health. So nursing finally had made it to the table of credibility, and that we are a powerful researching discipline. And so that's was noted by the National Institutes of Health. And we actually, like I say, had begun research earlier, but around 1978 there became an emphasis in nursing on qualitative research, and we're going to talk about the differences between qualitative and quantitative in a little bit. But that's how we gained recognition in the NIH. So you see, we have a very rich past, which helps us know that we have a very rich future. And here are some of our directions that we are moving toward. Certainly, you know that there's a heightened focus on evidence-based practice. That is the current terminology and word that we are using, because this evidence-based practice involves the integration of the best research evidence out there, along with some expert clinical expertise and patient needs and values, the things that are happening in the healthcare system, and all of these entities come together to produce evidence-based practice. There's also a greater stress on systematic reviews, and we're going to talk more about that and what that is here momentarily. But some of our other future direction includes more multidisciplinary collaboration. You know, we don't operate in silos. We really don't. We're surrounded by other disciplines that have significant influence in patient care. And so we really need to push toward collaborative research with physicians, dietitians, social workers, rehab therapists, and then share these findings, because our practice influences each other. Also, we really need to focus on expanding how we disseminate our research findings, how we let it be known what we do and what we have found in this research. And also greater focus on cultural issues and health disparities, because that continues to be a significant issue, particularly in this country. So as we are moving toward the push for research, let's talk about the types of research for a moment. There are two broad types, and the first is quantitative. When you think of quantitative, think of it in terms of numbers, rigor. It has got tight control over the research, and it's objective. What you want to be able to do with quantitative is you're going to count numbers, you're going to count the times that the blood pressure goes up or varies, and it's very controlled in its approach and research, because then you're able to generalize the findings. So quantitative is one type. And you're going to see that it can be descriptive. I love that typo. Correlational, quasi-experimental, or experimental in nature. The other type is qualitative, which is subjective. It's more to do with touch or feelings. It really is concerned with the subjective meaning of an experience to an individual. So the types of qualitative research that you will see are going to be ethnographic, historical, grounded, or a case study perhaps. So those are the two major types that I do want you to commit to your central nervous system. And here is another table that hopefully will help you understand the differences. This chart is on page 12 of your textbook, tables 1-2 and 1 and 3. And you can see that qualitative will help you identify that individual thoughts or feelings about certain things. You're not going to find that in quantitative. Whereas what you will find in quantitative rigor, control, is the ability to predict and control outcomes, where you will not see that in qualitative. Now they both describe, they both explore, and they both explain. Don't you like that? So reflect on that part of your textbook, because I do believe it will help you to differentiate the two types of research. Now, moving on to Chapter 2. We're going to be looking at the background of evidence-based nursing practice and where it came from, because it is a powerful, new, focused area of research. And there's some terminologies I want you to get used to hearing, because sometimes research utilization and evidence-based practice get used synonymously or interchangeably, but they are different. Research utilization is really you're translating empirical knowledge into application. And it's kind of like Nike, you just do it. You're justifying the standard of care and how we make nursing judgments. And it may be based on a smaller number of studies. Whereas evidence-based practice is much, much broader. It begins with research utilization, using the findings or evidence in one or two studies. But now we are using multiple research findings. We are using, systematic reviews and making clinical decisions and evaluating that. It's based on, as I said, the hospital systems and how they work, or healthcare agency systems and cost and patient outcomes. And so you're looking at a lot of factors with evidence-based practice versus research utilization, which is a smaller piece of the pie. And when we go to look for research or our literature reviews or what's already existing, I want you to know that there is a evidence hierarchy out there, and this pyramid really represents this. It's on page 23 in your textbook. Because when you are looking for data in the literature to make a clinical decision, you want to go to level 1, the highest level of evidence, which is a systematic review. It is the strongest because what you are looking at are multiple randomized clinical trials that have been implemented with rigor and control so that you are assured there is truth and credibility to those findings. And that's what you're going to use to base practice changes on. That is much more powerful because you're just increasing the body of data that you're using versus just one study that was a randomized control trial. Or if you come down that pyramid, you'll see a single non-randomized trial. And it goes all the way down to a case report, being there's still evidence and there's still value in an expert opinion or a case report. But if you're going to make clinical decisions and changes in standard of care, then you need to move up that hierarchy so that you're doing it with the best data available. And I'll give you an example. We've had the 10,000 nurses study that was published a few years ago, and they essentially looked at 10,000 nurses over about 30 to 40 years. And this was the study where they finally revealed that hormone replacement therapy was killing women with heart disease and breast cancer at phenomenal rates. And so when this study revealed that, it changed the dynamics of how women were prescribed hormone replacement therapy. And it made a significant decrease in problems in the death rate for women. So you see, that is an example of a systematic review when you're using multiple studies and layers of data. Isn't that cool? We also have the Jackson Heart Study that is actually located from the University of Mississippi Medical Center, particularly targeting African American and cardiovascular health. So they're publishing things all the time. So keep an eye out for that. All right, more about these systematic reviews. Remember, it is the biggest hierarchy. It is the best evidence to look for, because this systematic review is really a structured, comprehensive synthesis of quantitative and outcome studies. You're not going to find a lot of qualitative in the meta-analysis, or you're not going to find any actually. But you're looking at numerous high-quality studies for the systematic reviews. And the meta-analysis are where you're looking at these multiple studies because they are integrating findings across quantitative studies, because they pool the results from these previous studies and conduct a quantitative analysis on them. For example, breast cancer. There are several meta-analysis regarding breast cancer, and this is where they linked genetics and the genetic predispositions with chemotherapy for effective treatment. There was one recently published meta-analysis that looked at establishing the effects of walnuts on blood lipids. Well, this meta-analysis looked at 13 studies that met the criteria, and what they determined from those 13 studies and pooling those results was that walnut-enriched diets decrease the total and the LDL cholesterol levels, the bad cholesterol. Isn't that good? But they only did it for a short period of time, less than about 2 weeks. So they didn't have evidence for sustained or prolonged use. But isn't that good to know? Then you have a meta-synthesis, where you are integrating and amplifying findings from qualitative studies. And this is where you have a fully integrated description or explanation of a target event or experience, and you're developing a new perspective, perhaps, or a theory. And I'll give you an example of a meta-synthesis recently published where the researchers conducted a qualitative meta-synthesis to identify the essence of healing from sexual violence. Well, the researchers appraised 82 articles with a research tool that they had developed. The final sample included 55 studies, and from those 55 studies, they extracted 1,897 statements related to healing from sexual violence. Then they put them in themes, and what that ultimately led to were 11 statements related to healing and factors that influenced healing from sexual violence. So when you think about that, then you can help patients who are suffering from sexual violence and trying to recover. You can help guide your patients to come to these kind of 11 ways of thinking and relating and adapting into their life so that they can live and live well. So you see how this works. Isn't that cool? I know you'd love evidence-based practice. So that's kind of the skinny on systematic reviews, but just know they're at the top of the food chain when it comes to the research that we want to use to change practice. Now, here are some models, because when you start thinking about evidence-based practice, you're going to want to design and implement your own projects. I know you will, especially when you go to graduate school. And I know that's coming. Do not roll your eyes at me. Remember that, certainly those systematic reviews and all of those factors about clinical expertise come into play. And you don't have to know these models, certainly not for the test, but know that they're out there for when you want to create your own study. These are just the most significant. And you can certainly find these in the Cochrane Collaboration Collection. It has the most extensive collection of systematic reviews. But you can also find these through our Roland Library to use. It's just how you go about setting up an evidence-based practice project. So, how do you go about setting up evidence-based practice projects, and this is what you need to know. You'll be wanting to ask the questions that are answerable, and they're always started, even the systematic reviews are started by a clinical practice question, something relevant. Is there a better way to do something, a different way, or why have we been doing it this way forever? So you want to ask that question, and then you're going to search for what data research is out there. You're going to appraise it, synthesize it, integrate it into what you can, and then assess for effectiveness. And all the while, you're going to be doing this through using a formula known as the PCOT format. And it's on page 29 of your textbook. And this is what it represents. Your population. Who is it you want to study? Who are your participants of interest, or your subjects? What intervention do you think is needed for practice? What exposure or issue or nursing intervention do we need to assess and look at and test to see if there's a better way to do it? Your comparison of your interventions, what have we done in the past? What could we do in the future? I think about normal saline versus heparin to keep the Heplox patent. Well, that was certainly an evidence-based practice question that came to comparison. So you're comparing two different methodologies. And outcomes. What is it you hope to achieve? What in the outcome for practice? Is it cost effectiveness? Is it decreased pain? What are you wanting to see? And then time, the time frame. When will this happen? When is it important for these interventions to occur or the changes to occur? Now you're going to note that comparison and time have a star, and they're not always specified, or they're not always essential, but sometimes they are. But this PCOT formula is how you will go about looking to establish your own evidence-based practice project. Just like two authors by the name of Nicole and Hesby started using the PCOT format because there was a lot of uncertainty about the types of immunizations, the needle size, the site in which to give the immunization, and the problems or complications that resulted. So they began an evidence-based practice project, and they looked at the different studies. They went and found systematic reviews, and ultimately determined that for a basic flu vaccination, that the deltoid is the best place using a 22 gauge needle. And that is now confirmed empirically, and that's why we do it that way. Isn't that cool? So, the PCOT, very important. Now, as we move on to Chapter 3, I just want to say I understand some of this terminology and thinking is new and different. But the more you think about it, the more you increase your exposure to reading and thinking and looking at research and looking at practice, it really gets easier, and you start to find yourself thinking that way just like a nurse researcher all the time. And it is so cool. But we're going to have more details later as we continue moving through. But for Chapter 3, we're going to be looking at some research terms. Still wanting to expose you to differentiating between quantitative and qualitative. And this table is perfect because it really highlights some primary differences. The language is different for these two types. And I do want this to become part of your central nervous system, because I bet you're going to see it on a test. But just know that subjects and participants are going to be part of a quantitative terminology. An informant, if you see that in a research article you're reading, you can bet your bippy that's going to be a qualitative term. Phenomena is only going to be a qualitative term. You will not see that in a quantitative research study. Also, variables are only seen in quantitative research. You're not going to see a variable in a qualitative. See? Isn't this cool? It's amazing what you know already. So know that terminology and the differences. Also know that the places of research are important as you were reading and dissecting research studies, because it is important about where the study is conducted, the overall location, whether it's in Portland, Oregon, or whether it's in Bovina, Mississippi. That is going to impact your study and your study findings. And also the multi-site studies have a lot more generalizability, because if you're looking at pediatric clinics across the nation, conducting research in those settings, then that is going to increase your generalizability. If you were doing quantitative research in laboratories across the nation, growing cancer cells and finding a vaccine for cancer, that will give you a lot more generalizability to the study findings. So those are important terms to know as well. And I will tell you that whether you're in an urban area or a rural area, when you're conducting research, is important. Just to tell you a little bit about some of my research background, is in 2005, the Susan G. Komen Foundation published a study that listed Madison County, Mississippi as one of the 8 counties in the nation with the highest mortality rate from breast cancer. Well, those of us in the School of Nursing looked at each other and went, yikes, that's our backyard. We can't let this happen. And sure enough, what we discovered was, particularly with low-income African American women, they were diagnosed later, late stage, and often there was nothing to be done, but they were younger at diagnosis. So we set about to create a study and research where we educated women across Madison County using churches. We went to 10 churches. We educated people there to keep educating people. And we also gave women a clinical breast examination and a mammogram. Well, what was so cool about that then was, even though our study was small, we had 60 women, there were 3 women younger than 40 years of age that were able to be diagnosed with early stage breast cancer. And that was just in the 3-month project time that we did this study in. And so anyway, you come away from this realizing that settings are important, the type of research, and it does make a difference in people's lives. I love it. All right, some other terminologies to be familiar with have to do with concepts and constructs. This is like nailing jello to a tree sometimes. But study frameworks are very abstract. They are the abstract theoretical basis for a study that really link the findings to nursing knowledge. In my dissertation research, I used problem-based learning as a teaching method, where it was really student-centered learning, and attached that to Malcolm Knowles' adult learning theory. And it really fit beautifully, because most students love to know what they need to know immediately and use it immediately, and really kind of want to self-direct their learning. So concepts, and part of that, are really the abstract aspects of human behavior. They've got pain and weight there, but it's also things like creativity and empathy. And the thing to know is that both types of research, qualitative and quantitative, all research studies should have concepts and constructs noted when they go to publication and dissemination. So look for them. Now, constructs are a piece of concepts. Concepts are the broader sweep. Constructs are the building blocks, and they are just simply more complex abstractions, like Orem self-care theory. Well, self-care is one of those constructs. It's caring, it's motivation, it's kind of an intrinsic thing. So you might want to know that those are the differences between concepts and constructs. And theories and conceptual models really they consist of an integrated set of defined concepts that help to explain, describe, predict, and control phenomena. So when you're looking at studies, look to see that these three elements are even attended to. Some studies you'll have trouble finding them. But it helps you to link the findings in the study to the knowledge or the action that we as nurses do, or things, there may be gaps that we need to look at. And above all, remember that theories and research really doesn't prove anything. It simply suggests relationships. It suggests evidence of relationships. So, concepts and constructs. Variables. Now, when you get to the term variable, remember you're really only going to see this in that quantitative research. And that's just to describe something that changes. It's a different value and it varies. Concepts at various levels, and they're measured or manipulated or controlled for in the study. Some examples of a variable are listed here, but you can also include like temperature, blood pressure, those kinds of things. But it's something that you know is going to change, and it's going to vary. And there are types of variables. There's the continuous variable that does not change during the life of the study, like height and weight. Should not change unless you're making the weight change. But that is something that's going to be static or pretty much the same, versus categorical, which will be putting in a category of gender, marital status. Because when you're looking at variables in quantitative research, you're wanting to see if one has a cause and effect, or an association, or influence on another variable. The independent variable is the presumed cause. You're going to see these in experimental studies particularly. But it is the cause. It is the one that remains static. The dependent variable is the presumed effect. This is the one that will change because of the independent variable. So there you go. Independent variable is static, and it affects the dependent variable that changes. And let me give you an example here. It says here smoking is the independent variable that does affect lung cancer, the dependent variable. We pretty much know that that is true. However, not everyone who smokes gets lung cancer, do they? And not everyone who doesn't smoke is free of lung cancer. But there is a relationship. There's another study that's being done now about the use of gel pillows in the neonatal ICU regarding head molding in preterm infants. So the independent variable in this is what? It's the gel pillows. You're right. The gel pillows are what's going to be used all the time. And so that's going to be the one that is going to cause what we hope will be a difference in the bilateral head molding, which is the dependent variable. Very good. See, you've got this. So, all right, let's go on down here then to the definitions of concepts and variables. Once you identify your variable, then you define it. The conceptual definition is really just the theoretical meaning. It's kind of that broad overall sweep, where the operational definition is very concrete. And that is so it can be measured or manipulated. And let me give you an example to make it clearer, I hope. Those gel pillows and the bilateral head molding of preterm infants. Well, the conceptual definition will be bilateral head molding is an undesirable outcome in preterm infants. Okay. The operational definition will be there's anterior-posterior bilateral ratios of the cranium using a 6-inch caliper that measures less than 1 millimeter in difference. So you see, that operational definition then is really concrete. That's so you can measure changes in blood pressure, pulse, weight, or bilateral head molding. Very good. Okay. So these are the things you'll look for as you are reading research too. Conceptual definitions and operational definitions, and do they make sense? Data are another integral part. You're going to be, of course, datum is the singular form. And in quantitative, you are collecting the numeric data. It's numbers. Qualitative, it is verbal descriptions. And page 45 of your book really does a beautiful job of detailing this just a little more. Now, also on page 47, we're moving into now the research phases and steps. Quantitative and qualitative research basically have 5 phases, 18 steps, give or take a few. And even though they're like apples and oranges, they are different, but they are both great. And remember, we are seeking relationships. We are not proving things, but seeking relationships. And those relationships are really just a bond or a connection. Cause and effect. Well, we talked about smoking and lung cancer. But there's another study out there now that was actually a meta-analysis regarding weight gain and breast cancer. And it was identified that a 10-pound weight gain after the age of 17 for a female increased breast cancer probability by about 60%. So that was kind of a cause and effect relationship. If you gain weight, certainly 10 pounds or more increases your percentage of risk for breast cancer. Then there's an associative or a functional relationship that also emerges, like gender and life expectancy. We know that women in general live longer than men until the age of menopause, and then it kind of equals out. One may not necessarily cause the other one. Getting, being a man doesn't mean you're going to die young, or being a woman doesn't mean you're going to live to be an old age. But there may be relationships in there, just kind of an associative. For example, pet therapy in institutions are known to decrease hypertension and increase longevity. So while the pets may be having some influence on that, there may be some other factors as well. So just when we're thinking about those relationships, we're not proving, but we're just seeing what might have a relationship between those variables. So, what I do want you to commit to your memory has to do with page 47 through 55 in your textbook, because there's some great examples along the way, but it is the phases and the steps of the research process for quantitative and qualitative. And what I want you to know when we look at quantitative research, experimental research is the most rigorous. It is formal, it is objective, it is with tight controls, and this is where you're going to see those clinical trials in medical research conducted. True experimental research where they are giving medications to subjects and that they are closely following the outcomes of that. Because the whole purpose here, again, is to predict and control phenomena in nursing practice. Not really proving, but we can make assumptions based on that. Now remember, for the quantitative research, there are 4 types: the descriptive, correlational, quasi-experimental, and experimental. But remember, you can have non-experimental research within quantitative research. This is where, and we have a lot of behavioral research in this domain, where you might have researchers observing behaviors of people in certain circumstances. I know about drug research trials for compliance with medication use, and you are observing people in taking medications and those kind of things, and it's observational research. So it too has a place. Qualitative research is grounded in tradition as well. And there's a grounded theory research that really helps you look toward understanding key social psychological processes. And years ago, with a colleague of mine, we conducted research on the caregiver strain of persistent mentally ill patients. And we did interviews, and we'll explore more about how you do grounded theory. But what we understood after conducting these interviews of caregivers of loved ones who had terrible mental illness was recurrent themes about their own, the caregiver's, sense of depersonalization and loss of hope, not only for themselves, but for the loved one that they were caring for. So that was profound, and that gives you a sense then of how we as nurses can work with folks in this situation to help improve their quality of life. There's phenomenological research. Yeah, use that term over dinner tonight. And it focuses on the lived experience of humans. Dr. Shank in our faculty of the School of Nursing looked at the mothers of the preterm babies and what that was like for them, and really came up with some beautiful work. Ethnographic research really looks at the portrait of a people, looking at patterns and lifeways. And one of the studies I recently read for ethnographic qualitative research was where they looked at a study of families and the family presence and surveillance during weaning from prolonged mechanical ventilation, and what those patterns and what their thoughts and lifeways were. It was really kind of, it was enlightening to read. So, those are the major types of qualitative research. Now, here is what you're going to find in quantitative studies. These are the 5 phases we talked about. There are 18 steps. And if you'll notice that dissemination phase, phase 5, that's going to be important for all research. And that's because we need to publish and present. We don't need to keep these findings as hidden treasure. So when you conduct your research, and I fully expect you to do so, be sure to disseminate that information. And there are some specific activities in qualitative research, and it's just a little different. They have 4 phases and 14 steps, more or less. But there's the conceptualization and planning of the study. There's conducting the study through the emergent design. It unfolds. Qualitative studies just kind of are like a wedding. They grow and they evolve and they fulminate. It's just a hoot. So part of that also includes gathering and analyzing data. And that has a lot to do because when you're gathering the data, you're putting it into themes and into categories. And once you obtain saturation, that's the word, saturation, that's when the themes or the categories are starting to become repetitive. And that was when we were doing the grounded theory research, and we found that the caregivers had a sense of depersonalization and loss of helplessness or loss of hope for themselves. That became very apparent very quickly, and that was a point of saturation for our study. So that's just an example of some of those different activities. So as we move on to Chapter 4, this has to do with reading and critiquing research. And this is, again, is an overview. And how do you go about getting immersed into research? Well, go to some presentations, locally, nationally. Make sure you do at least one a year where you get exposed to the most current information, because usually those oral presentations or podium presentations are some of the newest, hottest research topics. So get out there and do it. Poster sessions. Now this is when you become a researcher. You are in to be a sin, yes. Because this is a great place for you to start disseminating your findings. Look at your unit and identify a problem and use that PICO formula to start an evidence-based project. Take it to a professional conference and a poster session, because that's an easy way for you to get in there and start exploring and using research. Now, journal articles are another significant way that we can disseminate findings. And certainly we reach the greatest number of nurses this way. But I encourage you to read 2 to 3 articles, research articles or journals a month, and use it in your clinical practice. Figure out something in there that you want to see or try or that you're going to look for. And remember, we talked about peer review and how important that is. That means 3 or more experts have looked at this body of work before it's deemed worthy to be published. So it's gone through some rigor. And these peer reviews are blind. I don't know of too many that are not blind, where these experts don't know whose work they're reading. So it couldn't be like my good friend. I'm looking at their article. It is a truly blind situation, so that you're getting that unbiased view. But anyway, read those journal articles. Expose yourself to the research. And when you're exposing yourself to the journal articles, here is a format to use. And this is IMRAD. You're going to find these in all articles. And look for them. Page 69 and 70 in your text rock, because it really takes you through the questions to ask about critiquing the research. And these are the areas you're going to look for in every research article. First of all, you're going to look at the title and the abstract. It's going to be a brief overview about the major features. And it's going to be a snapshot. Now, I will tell you, you can get into the Cochrane Library and PubMed and CINAHL and hit those keywords that you're after, and you'll just be given lots of research articles to pull from. UMMC has a fabulous nursing research site, and I encourage you to get in there and look at that as well. But you'll start with the abstract to see if it's something of interest and relevance to you and your practice. Then you're going to move into the M, the methods. Now, with the quantitative studies, you're going to look at, you'll move through the methods and you'll look for the headings, because you're going to look to see if is the research design applicable? Is it something I could replicate? We're going to talk more about research design later. But the sampling plan and the characteristics of the study participants, gosh, is the target population defined? How were they selected? Did the authors talk about what inclusion or exclusion criteria did they use? Were the methods of operationalizing the variables and collecting the data, were they defined well? And then study procedures. Did that include the procedures to protect the participants? That is a big, fat, hairy deal. No matter what research we do, we have to protect our subjects and our participants. And then what were the methods and the procedures for the statistical kinds of things? How were they applied and did they make sense? So you'll look at those, certainly for the method sections in quantitative. And then in qualitative, what was the research tradition? What type of qualitative study was that? And I encourage you really, you're not going to see statistics in this qualitative side. But you're going to be looking again at the sampling approach. Were the study participants, were they described? Were they appropriate? In what setting and context did this happen? And then what were the procedures? Did they achieve saturation? And then those analytical strategies as well. That's the M. And then we move to the R, the results section. And this is the IMRAD formula that you'll use for all of your critiques. And when you get to quantitative studies, this is where you will look for those statistical tests. And you don't have to be an expert with them. You will be when we have our session in a few weeks about statistical analysis. But you'll be able to look at it and see, gee, does this make sense? Because the p-value is the statistical significance, and they are keen in looking at what is statistically significant. Not clinically significant, but statistically significant. Now, in quantitative studies, you always want to look for the p-value, because most studies do cite the p at the less than 0.05. You may see them at a 0.01. But that really just says that there's 5 in 100 chances that it is the wrong information or that is not correct. So you just want to look to see that the authors have identified levels of significance and what those things they discovered that were significant. Because what you're indicating here has to do with reliability and validity. They are the bread and butter of the research recipe. Have you ever made a cake without butter? It may not be so good and won't hold up. And the same thing is true. If you're missing some of these sections and they're not defined enough, then you might have issues with the reliability. Now, on to findings regarding qualitative studies. Yeah. Do you see the categories or the themes that have been identified? Are they organized? Is there a discussion? Because you may see numbers, but it's going to be a discussion in terms of how many people indicated a theme or a category or a concept. For example, in that grounded theory study about the caregiver of the persistent mentally ill, we had 100% of our respondents indicate that they had lost a sense of self and they had lost hope for themselves. And so that was a saturation point that we identified when we published. And it always includes raw data. Now, discussion. When we talk about the discussion in the IMRAD formula, you're going to see that for both types of study, quantitative and qualitative, because you're going to see the interpretation of the results. This is the so what. Out of all this data and all these numbers for quantitative and reports and themes for qualitative, what does that mean for nursing practice? And it is an important section when you see the implications, because can I as a nurse replicate this study or use these results in my clinical practice? Can I replicate it? Can I do it in a different venue? So those are important sections to look for, and our study limitations discussed. These are the things that impact the generalizability and transferability of a study. Was the study sample too small? Too many people didn't return a questionnaire? Or maybe we were looking at mothers' post-abortion reaction 10 years after the abortion, and there's a recent bombing of an abortion clinic. That's going to impact your study. That is going to be a study limitation. So, are they discussed? And so that takes you through IMRAD, and that's a good way to dissect your research articles. And here are some more tips. There again, read 2 to 3 articles a month and start collecting your articles as you read in your clinical domain. It will come in very handy when you move to graduate school, because you will already have a body of references and knowledge to pull from. You'll be a lot more familiar with the terminology. And I think it's a good idea. Ask for Christmas or your birthday for a journal article or a journal subscription for yourself, so that you can keep abreast and they come to you regularly. And also join Sigma Theta Tau. It is the only honor society in nursing, and it is research-based as well, and it gives you a great networking internationally for research. So I encourage you to do that. Now, just when you thought we were about done, we have a few more terms, because as a savvy nurse researcher, I just want you to know these things. That triangulation is probably the cat's pajamas, because you are using strategies from both qualitative and quantitative research to bring together a really good evidence-based practice project, because it builds credibility, trustworthiness, and generalizability. And you're just using 2 or more theories, methods, data sources, investigators, or even analysis methods in a study. For example, that breast health grant we did. Our educational piece, where we trained the trainers in the churches, and we educated the women on self-breast exams. That was all our qualitative piece. Whereas when we actually performed the breast exam and we sent them for mammography and we got the results back and we referred them on, that was all quantitative. And those two things came together, we think, to make powerful influence. Triangulation. Bias. Well, this is just when there's something that happens that distorts the study. The most frequent bias occurs with sampling. And that's when you're selecting your sample, something goes awry. Let's say you are selecting your sample using the phone book and you choose every third name. Well, there is a built-in bias because you're looking only for those subjects with a phone, a home phone, because nowadays everybody has a cell phone, so you're not even getting those numbers. So you see how that works? Yeah, it's beautiful. So, but bias can come in a lot of ways. Faulty methods, participants don't disclose what you're looking for, preconceptions by the researcher, and just a faulty study design. So bias is something important to note. Research control. This is in quantitative studies, you are really trying to control, right? So you really look for things to make sure you don't have bias introduced. But by George, those little things sneak in there. There's this little pesky thing called extraneous variables, or confounding. Extraneous variables happen before and during a study, and then a confounding variable will happen after a study. But just know, they exist in all studies and really represent the fly in your research soup because it keeps you from the truth. But you try to recognize and control these things with the criteria and how you set up your study design. And let me give you an example. So you're researching the levels of depression with a myocardial infarction. And you're collecting your data, and by George, you were in New York City when Hurricane Sandy hits. Well, you think there's going to be an awful lot of heart attacks happening? Yes. Do you think there's going to be an awful lot of depression happening? Yes. So therefore, you have got a boatload of variables that are going to affect your research. So you try to control where you can. Oh, all right. Randomness is something that I think is important to note, and that the more random your sample, that is a way to control, and that the more random the better, and the more experimental the better in qualitative research. So, because all of this comes together to help make the generalizability in quantitative research and the transferability in qualitative research true and rich and credible. So, I hope that you have gotten inspired here. Be sure to read your text. Go back through and highlight on your PowerPoint those areas that we talked about. And I will talk to you soon. Take care.